My preferred way to do it is right after cystoscopy. So flexible cystoscopy diagnostic, bladder's full, literally patients off the table, cuffs at the bedside. They don't have far to go. And we get all that information. I come back in the room, they're dressed and comfortable. I've got cystoscopic findings. I've got UroCuff results to share with them. And it helps me talk them through my diagnosis and the potential treatment options. The UroCuff often makes sense, right? So we have our clinical suspicion based on anatomy, prostate size, how the bladder looks. And so oftentimes it will be confirmatory of those findings, but there are cases where the clinical picture is not clear. You know, the way the anatomy looks maybe doesn't jive with or agree with what the patient's complaints are. And that's where it can be particularly useful. You may uncover obstruction with a smaller prostate, or you may have a bigger prostate that you find it's obstruction is not the issue, and there could be overactive symptoms there. So I think it can be confirmatory of your suspicions, but also it can, perhaps help you sort out those more challenging patients. Absolutely. Yeah. Particularly in that patient with a lot of overactivity symptoms, you look in with a cystoscope, not a huge prostate, not overwhelmingly suspicious of obstruction. And then you've got your UroCuff that shows he's unobstructed. And so, you got to revisit, what are the complaints? Why is the patient here? Got to kind of regroup. Maybe you were going down the wrong path because BPH is so common. That you may have been appropriately exploring that option, but now it's time to maybe switch direction and look at other irritative voiding habits, dysfunctional voiding, overactive bladder, these kind of things. I think it definitely impacts procedure volumes because it's a quantitative analysis that I can share with a patient, and I can show that patient that that they're that the UroCuff may suggest declining bladder function. So I can show them that their bladder is functioning at a very high pressure, for instance, a high pressure, high flow state. I can show them that you're compensating now, you're maintaining flow rates, but you're doing it at very high bladder pressures. And I use the sort of the cycle or the evolution of lower urinary tract symptoms. I use that on the UroCuff printout. So for instance, I'll show a patient, say you have a high pressure, high flow patient, I'll show them, unobstructed. This is where you were when you were 16 years old. You're 52. This is where you are now. If we do nothing, in another few years, you're going to be obstructed. And if you continue to do nothing, you'll be in the low pressure, low flow category. And that's where nobody wants to be. There's not much we can do there. That's, severe bladder dysfunction. And that's why there's, late night commercials for catheters, because we don't have a lot we can do. And so I try to show the sort of cycle of how this can evolve and educate patients so that hopefully they can be encouraged to reduce their risk of ending up in an obstructed or a low pressure, low flow situation. And they can do something, whether it's Flomax or a TURP, they can do something to protect bladder health and function. Absolutely, it does. Yeah, because it helps me with counseling patients because I can show them, you have a good, strong bladder, your bladder pressures are high, but your flow rate is low. So that's the prostate's doing, you have resistance, at the outlet. And so if we can address that, whether it's UroLift, TURP, et cetera, if we can do a deobstructive procedure, then we expect to see you shift on the UroCuff graph, the results, the nomogram. We expect you to hopefully get into that low pressure, high flow state, unobstructed. Yeah. If you're in the obstructed category, I'll show them that, at this high bladder pressure, if we could deobstruct your prostate, your flow rate's going to go from 4 to 20. I'll carry it across the curve, and I'll show them at this pressure, you'll be at this flow rate. And so I think it's helpful for them to understand that if we can deobstruct, that they'll see significant improvements in flow rate. It does. Yeah. Low pressure, low flow is a tough patient. I'll still counsel them that if I can decrease resistance, you may do better with emptying, more efficient, complete emptying is possibility. In severe cases, it may be somebody I'll offer them an SP tube at time of TURP, something like that, because they're going to be difficult potentially to void trial, or they may fail despite deobstruction. So it certainly alters management and expectations. Yeah.